studies. The summary of these, which is LIXI-O and LIXI-L, it shows that it improved HbA1c and it dropped it from 8.5% to 6.5%, which is logic, comparing to basal insulin alone or Soliqua alone. And also they found it is superior than Soliqua rather than just the basal insulin. And there was slight weight reduction around 1.4 kilogram. And more than 50%, 55% of patients reached the target of less than 7% with no hypoglycemia, comparing to basal insulin. Is it better than the bolus insulin? Yes, there is another study on Soliqua, Get Gold DO2 study, comparing the Soliqua to insulin, basal insulin plus 1 or basal bolus insulin, which is 4 times injection. Again, it found probably they are the same regarding the HbA1c, but no hypoglycemia, and there is slight weight reduction. We have 2 pens available in the market, which is the 1040 and 3060, and I'm not going to go in details. The other combination that with the insulin deglutic and liraglutide, which is Zolpidem, which is simple and you can use it. Soliqua, you have to give it 1 hour before the meal, 1 hour before breakfast. But Zolpidem, you can give it at any time, not related to food. You can give it at night, and it's very easy to titrate, and just 1 pen. And fixed ratio, having the 100 unit per mil, and liraglutide the 3.6 milligram per mil. And the Zolpidem here, it's very easy. You can stay not on basal insulin or GLP-1 receptor, just naive there on oral. You can start only 10 units and titrate by 2 units every 3 days or 4 units every week. It depends, and you can easily teach the patient. And also you can only have 1 blood glucose monitoring 1 time, which is the fasting blood sugar. You don't need to check the sugar 3 times a day. And there are plenty of studies on this Zolpidem from dual 1, 2, 3, etc. And again, just summarize it, that found it is superior in all the studies that Zolpidem, insulin deglutic, and the and liraglutide is superior to basal insulin, to glargine, or just to liraglutide in lowering the HbA1c, improving fasting and postprandial with minimal hypoglycemia. Very, very rare to have hypoglycemia. And we are going to use less insulin, around 50% or 30 to 50% reduction in the number of insulin units that we are using. That's why we have weight reduction and less hypoglycemia. So certainly, in just summarize here, the dual 7 for insulin deglutic and liraglutide, glargine and insulin aspart here, that there was significant reduction. Okay, the HbA1c is not inferior, but superior regarding the hypoglycemia, superior regarding the body weight. There was a reduction by 3.5 kilogram. Insulin dose, again, probably halved, so it is superior. And number of injections, said just 1 injection, easy to titrate. If the patient already on basal insulin, you can start or 16 units and titrate. Or if he is on just liraglutide, again, you can start 16 or 10 units. So basically, this combination, it shows that fewer injection, 1 injection a day, improve the adherence, which is very important for the patient. There was less glycemic variability, less glucose monitoring required. You need only to check fasting blood sugar, lower insulin dose. There is significant reduction in body weight, at least when we compare Zolpidem to just basal insulin. Less hypoglycemia, minimal. What about the GI side effect, which is always accompanied with the GLP-1 receptor agonist? It is less than using GLP-1 alone, because we start a small titration or a gradual titration. So fixed ratio combination basal insulin GLP-1 receptor agonist in the clinical practice, certainly probably all patients type 2 diabetes, not type 1, contraindication in type 1, type 2 diabetes, not achieving the target on maximum oral hypoglycemic agent. You think that your patient need an injection, either basal or GLP-1, it's better to give combination. So any of those patients already taking basal insulin but not at the goal, not taking insulin but not at the goal, or taking GLP-1 but not at the goal, but it's important that those patients, for example, he is already on GLP-1 and SGLT2 inhibitor, sulfonylurea, etc. You need to add basal insulin. Better to have a combination. Is it really in the guidelines? Yes, it is in the guidelines in the Diabetes Association guidelines. And this is my last slide as to take-home message. I urge everybody to be a responsible prescriber. You are alone in your clinic, in front of the patient or over the phone nowadays, the telemedicine, to be responsible. Why I am prescribing this drug? Is it beneficial? What are the benefits? What are the side effects? You have to say, is the patient happy with the medication? We have to discuss it all the time, explain the side effect and the benefit, simplify the medication, which is very, very important because our diabetic patient already on a lot of medication and certainly has here something new, next exit, hoping that we will have more and more fixed ratio combination for treating our diabetic patient. Thank you very much.
Thank you, Dr. Saeed. Was a nice presentation, nice review regarding the new combination for treatment of patients with type 2 diabetes. Thank you. Thank you very much.
Thank you.
I want to stay with us and we'll receive the questions at the end of the session. Thank you, Dr. Saeed.
Thank you.
I now will go for the next presentation. The next presentation, it will be presented by Dr. Ayman Morsi. Dr. Ayman, he is a consultant and the head of Department of Adult Endocrinology Department at Noor Specialist Hospital in Mecca. And he is also the chairman of the Non-Invasive Cardiac Service. And he is going to talk about the challenges of managing the dual existence of diabetes and heart failure. Welcome, Dr. Ayman.
Yes, thank you very much for this perfect introduction, and thank you to everybody which is inviting me, especially Dr. Severay. My talk is part of Cardiometabolic Alliance. So my talk today is heart failure burden. I'm a cardiologist, by the way. I'm not endocrinologist. So I speak very, very quick about the endocrinology part, and then I will speak something deeply about cardiology. Heart failure burden, I think everybody agree, it is still in one spot. Type 2 diabetes and the cardiovascular disease physiology. Third one, standard of care of patient with type 2 diabetes. Recent anti-diabetic therapy, which is improved cardiovascular outcome. Evolutional of glucose-lowering therapy by summary. And number 6, which is our thinking supposed to be become very fulfilled. What's the new treatment of heart failure in 2020? And lastly, not least, SGLT2 inhibitor in heart failure. I think it is presented very well by our colleagues, the diabetologists. I will say only one thing about unanswered question till now. And lastly, not least, take-home message. I think heart failure burden and the classification in one spot, I think you agree with me, 64 million people all over the world have heart failure. In 2025, 30% it become heart failure globally. 9 of 10 of patients of heart failure is still symptomatic in spite of therapy. Mortality, 5-year mortality of heart failure is more than 50%, and it is more and exceeded than any type of cancer, especially prostatic cancer. 10% for costly of patients died during first heart failure hospitalization, and then the second hospitalization is always less than 18 months. So frequent, progressive, deeply costly. Although these obstacles, but I can say openly, can be preventable and treatable. Heart failure for other colleagues, not cardiologists, I think it has become very fair now. HBrEF, hip mid-range. Heart failure with reduced ejection fraction, which is less than 40. Heart failure with mid-range, which is 40 to 49. And then heart failure with preserved function, which is ejection fraction more than 50. I remind everybody, BEF, it is not better than REF, to close the story short. Don't say heart failure with reduced ejection fraction, the mortality is more and more than HBrEF. The answer is no. both of them, the mortality approximately the same. Second issue is type 2 diabetes and the cardiovascular disease. 50% of people with type 2 diabetes die from cardiovascular disease, and type 2 have twice the risk of cardiovascular disease compared to the general population. Globally, approximately 1/3 of patients with type 2 diabetes have cardiovascular disease. And these slides, we like it as a cardiologist. Always the cardiovascular is continuum. Start by risk factor, and the top of risk factor is diabetes, and end by mortality. So more risk factor lead to subclinical, which is main issue of subclinical cardiovascular physiology is endothelium dysfunction. And then clinical damage by CED, cardiac thrombosis, MI, and end by mortality. So these slides, we like it as a cardiologist. We can say here, when this patient is already diagnosed as a diabetes in this era of his life, you can say 15 years before patient already have cardiovascular risk factor. And around 10 years is already development atherosclerotic disease. And then shall you believe, patient is today diagnosed as a diabetes is already fulfilled and the development macrovascular complication. So 10 to 15 years early, the cardiovascular patients have died with diabetes. And in spite of advances in standard of care and therapy, the most of the patients of type 2 diabetes still died from cardiovascular disease. And this slide also is very nicely. If our age approximately 60 to 70, so the patient, if he have diabetes alone, this age decreased 6 years. If it is diabetic and cardiovascular, his age is decreased up to 12 years. That's why European guideline in cardiology 2016 consensus say openly, patient with diabetes and at least one of other cardiovascular factor or target organ damage should be considered as a very high risk patient, like this way, this 2019. They mentioned very high risk patient is the patient of diabetes with established cardiovascular disease or other organ damage, or 3 or 4 major risk factor, or early onset of type 1 with long duration more than 20. See now what is the definition of very high risk, which is most of our patient is now is very high risk. If you say high risk only without very high, patient with diabetes more than 10 years only, even without target organ damage, plus other additional risk factor is considered as a high risk. These slides, endocrinology is that always we listen from them. The intense, as if our colleagues mentioned now, more intense therapy, nothing important. So if your patient is become more intense, you can ask for more mortality, more cardiovascular death, more than non-cardiovascular disease in compared to the less intense. So we need something, medications apart from the usual regimen. So here we like these slides also. Type 2 diabetes is a major risk factor of heart failure. This Framingham, which is the mother of our study, they mention here, population attributes the risk of development of congestive heart failure is diabetes here in compared to the valvular or LVH or diastolic dysfunction or MI. Again, the multinational registry, which includes the mega number of the patient, 772,336 patients with type 2 diabetes. They mentioned first comorbid is heart failure and then CKD before heart failure, apart from peripheral vascular disease, MI, and stroke. So the standard of care of patient of type 2 diabetes from the issue of cardiac point of view, see how is the American Diabetes Association mentioned? To tight glycemic control is last step of therapy, is here. So we need to make it all this therapy or maneuver of your patient of diabetes. Don't consider control blood sugar is the only way. No, we need tight blood sugar control here, but we need blood pressure control at less than 140/90, LDH by any guideline you wanted. And the guideline now is become very clearly. So if your patient is very high risk, is LDL less than 55, if it is high risk only less than 70, please smoke stopping, individual diet, lifestyle, and weight loss. So the American Diabetic Association recommended for the management of type 2 diabetes 1, 2, 3, 4, 5 before glucose control. So this is a recommendation of antiplatelet therapy for primary prevention, which is very common question in our practice. My colleagues, I am now become 40 or 45. Shall I take aspirin therapy or no? So the answer here is very clearly, if your patient is diabetic and the high or very high risk, you can give aspirin therapy 75 to 100 may be considered for primary prevention and the class 2B indication. Class 2B indication supposed to be, say, thinking more before you give him. But if your patient is diabetes alone with moderate cardiovascular risk, you harm the patient if you give aspirin therapy. This is my message for everybody, non-cardiologist. So aspirin, it is not a coffee in the morning, which can be taken. And even if you give aspirin therapy in order to your patient is high risk, just please give some protein pump inhibitor by class 2A. Shall you believe now? So protein pump is class 2A and aspirin therapy is class 2B. So try to say no. Try to say no aspirin for primary prevention. This recommendation for treatment of heart failure in patients with diabetes. Definitely everybody knows ACE and beta blocker therapy are indicated for symptomatic patients with HFrEF and diabetes, class 1. MRA, which is mandatory now for HFrEF patients, and this is again class 1. Device therapy, which is what you can say electrical therapy of heart failure, like ICD, CRT, or CRTD, again, it is recommended, especially if your patient profile is good for CRTD and the QRS duration is more than 150. Angiotensin II blocker therapy is second option of ACE inhibitor. Don't start your patient with heart failure by angiotensin II blocker first. Now, ACE inhibitor, and if the patient has any contraindication of ACE, just replaced by angiotensin II blocker. Now is ARNI group came in the top of the list. ARNI group, secpetrol, valsartan, it is indicated instead of ACE inhibitor. So just inform of all of your colleagues, any patients stable in ACE or angiotensin II blocker, please remove them and give in secpetrol, valsartan, which is called ARNI group by class 1 indication. Diuretic therapy, although the diuresis is only decreased symptoms, not any relation between mortality, but it has become class 1 if your patient is congested. Lastly, not least, make revascularization therapy by coronary artery bypass surgery, especially your patient anatomy is 3-vessel disease or LED proximally. Lastly here, recommendation again, ivabradine therapy, it is highly indicated by class 2B, 2A, not B. Before it's 2B, now it's jumping to 2A, but to give ivabradine have characteristic features. If the patient have breath and the heart rate is sinus and more than 70. So if your patient beta blocker therapy cannot be achieve the heart rate around 70, and still you give big dose of beta blocker and the heart rate more than 70, and your patient is sinus rhythm, by class 2A indication, please give ivabradine therapy. Lastly, not least, no any rule now for direct renin inhibitors. What is the recent anti-diabetic therapy which is improved cardiovascular outcome? This is what we can say here. Cardiovascular remain leading cause of mortality. So what is ECC consensus in 2018 mentioned? We want to arrive to a new agent proved to reduce adverse cardiovascular outcome in patients with type 2 diabetes, has triggering as a major paradigm shift beyond glucose control. So the recent development of SGLT2 inhibitor and GLP-1 receptor antagonist has demonstrating that treatment development for glucose lowering can directly improve cardiovascular outcome. So there is need to incorporate the use of this agent in patients with type 2 diabetes and the clinical atherosclerotic disease purely to optimize the cardiovascular outcome, no relation to diabetes. Lastly, this one which we like it in order to, it's very summary here. So what is the SGLT2 inhibitor cardiovascular outcome individual? You can say clearly here, This one is DIBA, EMBA, CANA. This is the only one. These three medication, which is SGL2 inhibitors. DIBA here, which is by big, large trial, which is 17,000 patients, which is declared, TME58. And this 7,000, which is EMBAREC. And lastly, 10,142 in CAVUS. What we can say here for the total difference between all of them, I think the endocrinology normalizing. I want to like to stress in only one point. The declared TME58, it's not issue of large trials alone. No, it is issue which is the population is 40% for secondary prevention, and more than 60% is primary prevention, which is important for us, primary prevention. In EMBAREF, 99% of the population is only for secondary prevention alone. But in CANA, 66 in cardiovascular disease, which is second prevention, and 34, which is multiple risk factor. What we can say all over here, we are interested as a cardiology here, heart failure hospitalization. So for DIBA is perfect for heart failure hospitalization as a second prevention and also as a primary prevention. For EMBA, it's very nicely to say openly, it is very nice for secondary prevention, but for primary prevention, it is not available, right? In other issue, in CANA here, approximately the same. It is very perfectly here in second prevention, but in primary prevention here, it is non-inferior. I think it is very clearly. About cardiovascular disease, it is not ARCOB, it's heart failure mainly. So I speak about heart failure. Don't say one SGL2 inhibitor is better than others. But I can say openly here, according to these guidelines, they mention here, DIBA is better for primary and secondary, EMBA for secondary, and the CANA for secondary. Lastly, not least here, for CANA, 33%, only one slide, 33% decrease for heart failure hospitalization in compared to the placebo. On the other hand, in the patient for cardiovascular death or hospitalization for heart failure, so the comparison between CANA and the placebo is 22%. And lastly, not least, for DIBA here, DIBA, you can say here, the dose is only 17% relative risk reduction of heart failure hospitalization and the cardiovascular death. And these three arming make it easy here. Heart failure with cardiovascular death, 38 relative risk, DIBA and placebo. Heart failure hospitalization alone, 36 relative risk reduction for DIBA. And also cardiovascular death alone is 45% relative risk reduction in compared DIBA to the placebo. On the other hand, in EMBAREG outcome summary, we are interested here for heart failure hospitalization, 35% decrease of heart failure hospitalization in compared to the placebo. EMBA make it something important, which is EMPRESS study, which is supposed to become in November 2021. But we mentioned it is mega slide. You can use DIBA with optimal, max screen, Medicare, which is compare what? Compare EMBA to DDB4 inhibitor. And the number of the patient is magically more than 200,000. But they say here, it is mostly, in order to that line, it is off-label till now, mostly 44% in compared heart failure hospitalization in compared EMBA versus DBB4, but it is off-label till now, which is continue the randomized clinical trial of EMBA outcome, which is 35% compared EMBA versus placebo. So that's why the dosage, I think everybody knows, 10 milligram in EMBA, 10 milligram in DIBA, and 100 CANA. Please, this class of anti-diabetic therapy, don't give into, make it say no in pregnant nursing patient, ageless 80, so it is not suitable for type 1, age more than 85. Lastly, not least, evolutionary glucose lowering therapy by summary, to make it very simple for everybody, based on inconclusive evidence and the cardiovascular safety warning with older glucose lowering agent 2008 FDA mandated that the new diabetic drug demonstrated cardiovascular safety in cardiovascular outcome trial. The cardiovascular outcome trial have demonstrated that some glucose-lowering therapy have beneficial effect in cardiovascular and kidney outcome. Social recommendation and the clinical guideline and the position statement has been updated to reflect the least evidence reduce the cardiovascular mortality for patients of type 2 diabetes. Still the issue of SGLT2 inhibitor will continue to added evidence base, including investigated their effect of heart failure and the kidney disease outcome in patients with or without type 2 diabetes. For FDA Saudi till now, they are not making us to give medication SG in heart failure, except if the patient heart failure with diabetes. Lastly, not least here, what is the new therapy of heart failure in 2020 in relation to diabetic? You can see here 5 pillars in heart failure with reduced ejection therapy in 2020. You can say clearly now, SGLT2 inhibitor is one of these pillars nowadays into 2020. I think ACE and angiotensin blocker, ARNI group, beta blocker therapy, MRA, and the number 5 in pillow is SGLT2 inhibitors. That's why when we say something, you need to use a good evidence base. The ACE and the angiotensin blocker in HIPREF patient, it is guided by a lot of mega trial, which is CONSENS trial, SOLVIT trial, and CHARM trial. In beta blocker therapy, is CBS, which is an bisoprolol therapy, MERT in metoprolol tertiary therapy, and Copernicus, it is in carvedilol therapy, and lastly, SENIOR study, which is nebivolol therapy in beta blocker therapy. RAILS trials, which is MRA. Lastly here, ARNI group, which is evidenced by paradigm heart failure therapy, SGLT2 inhibitor, which embadibacana, and which is mentioned very quick, vabridine therapy, which is guided by SHIFT trial, which is class 2A indication, and Vricacet, which is very important. You listen a lot in the coming days for Victoria trial. So the drug for management of heart failure therapy now is become very easy. MRA, SGLT2 inhibitors, ARNI group, angiotensin blocker, beta blocker, and loop diuretics.
Lastly, 1 minute, huh? 1 minute.
Okay, perfect. I'm in the timing. So the huge benefit of combination therapy now, which is published in May 2021, 2020, they mentioned very nicely, conventional versus comprehensive therapy for heart failure. Conventional mean RAS blockade and beta blocker alone. Comprehensive mean RAS beta blocker with ARNI group, nebulizer inhibitor, MRA, and SGLT2 inhibitor. They can see very magically here when you make it comprehensive versus conventional therapy, you ask for decreased cardiovascular deaths in heart failure, cardiovascular deaths, hospitalization for heart failure, and all cause of mortality. SGLT2 inhibitor, which is an answer. I think combination of SGLT2 inhibitor and the ARNI group soon will become in the market. Risk of polypharmacy and adverse action supposed to be put in our mind. The use of vulnerable heart failure and type 2 diabetes in elderly, which is frail and multiple comorbidity. And the mechanism again here is not clear. How SGLT2 inhibitor is prevent or decrease heart failure or improve heart failure hospitalization, still till now nobody knows. But we believe as a cardiologist, it is make more natriuresis, reduce interstitial edema, decrease diastolic dysfunction in this parameter. When something in the medicine not clear, you can use something which is magically. You can say improve cardiac bioengineering, which is nothing, nobody knows what you mean. Improve kidney function and the cardiac kidney pathology or physiology. But for cardiologists, we like natriuresis, we like LV dysfunction improvement and reduce preload and afterload. Lastly, not least, take-home message, my colleagues, heart failure is still big burden. Type 2 diabetes and the cardiovascular disease treated together as alliance. SGLT2 inhibitor considered as a gold standard therapy for heart failure in patients with or without diabetes, according to the FDA Saudi, still not give us permission to give SGLT2 inhibitor in patients with heart failure without diabetes. Remember, lastly, the new 5-pillow therapy in HIPREF patient. And thank you very much.
Thank you, Dr. Ayman, for the excellent presentation. with discovering the new medication, which are good for both treatment for both diabetes and cardiovascular disease. Now we have a nice and a good connection between the cardiologist and the endocrinologist. Thank you, Dr. Ayman Morsi. Thank you.
Thank you. Thank you.
It's my pleasure now to introduce the third speaker, Dr. Walid Al-Habib. He's a consultant cardiologist at King Saud University, and he's going to talk about the principle of heart failure, reduced ejection fraction management. Welcome, Dr. Walid. Welcome. The voice, yes, Dr. Walid.
Yes. Sorry. Thank you very much for inviting me. It's a real pleasure to be in this very nice and fruitful meeting, actually. And as you said, the connection between cardiology and diabetes is becoming, cardiologist and endocrinologist is very strong. But I think one day we'll be taking over fully diabetes as well. But without further ado, full screen, no, okay. Now, Dr. Morsi, mashallah, gave a very good introduction about heart failure and its burden, so I won't spend too much about the mortality and morbidity of heart failure, and I would focus more about the actual principles of management, which was asked to me by talk. Just to tell you in a nutshell that the inpatient mortality is about 4%, and in 60 days that goes up to 30 to 50% mortality after a hospitalized patients. And 40 to 50% of these patients are expected to die within 5 years. So it is a big issue that we deal with. I always like to show this staging of a heart failure, the ACC, AHA staging of heart failure, American College of Cardiology, American Heart Association, because although we mostly focus on what is called stage C, the presence of the classic symptoms of heart failure, which we know about, signs and symptoms of shortness of breath, orthopnea, PND, edema, but we shouldn't forget that this is preceded by 2 stages, actually. Stage A, as you can see here clearly, just those who have risk factors, hypertension, diabetes, obesity, metabolic syndrome. These patients are the milieu and the later progression into the actual classic heart failure. Unless we focus clearly on managing these patients and prevent them from progressing into the stage C heart failure, then we're missing the boat and probably too late to manage. And that's why I believe the connection between diabetes and heart failure comes very clearly from the early stages. Very importantly, just to focus, I know Dr. Morsi mentioned it, this is from our Saudi Heart Association guidelines, but just when we talk about reduced ejection fraction versus preserved ejection fraction, we only base it on the ejection fraction by echo or by imaging in general, echo or nuclear studies or MRI. The ejection fraction of 40 or less has been labeled as reduced ejection fraction, while those above 50% have been labeled as preserved ejection fraction. And of course, that leaves a 10% in between 40 and 50, and it shows you just exactly how much we don't know about heart failure, because the reason we have divided it this way is that most of the medications, most of the therapies that have been proven beneficial in heart failure are in the reduced ejection fraction category. Unfortunately, we struggle to manage those in the preserved ejection fraction. Most of the medications, most of the studies have failed to show any benefit, although they act the same, they look the same, they present with the same signs and symptoms. As Dr. Morsi said, they probably even have the same outcomes and mortality. But when it comes to therapies, we are very short when in preserved ejection fraction. Most of our therapies work in the reduced ejection fraction. Now, this range in the middle is just because we haven't studied them clearly. Most of the studies would either take the low ejection fraction, 40, 45% or lower, or above 50% or 45 and above. So there was not much of focus on that middle range, and they are moving towards studying them more and more. Many authorities would actually treat them the same way they treat the reduced ejection fraction. So back to the principles of management, and why do we choose these medications? Why have these medications that Dr. Mercy has mentioned, and I'll mention in a while? Why are we thinking of them? It's because heart failure is basically a neurohormonal disease. It's a neurohormonal syndrome, where basically, when classically we think of a low cardiac output from the heart, and that's the basic mechanism, although there are other ways, other causes of heart failure, but the basic is low cardiac output will stimulate the body to act in a compensatory mechanism, where they're trying to compensate for that reduced ejection or reduced cardiac output. The sympathetic trunk will increase its adrenergic system. It will activate the beta and alpha receptors, beta mainly in the heart to cause more inotropy, more chronotropy. The kidney will see lower cardiac output, and unfortunately, it cannot differentiate whether this low cardiac output is because of actual low perfusion or low volume. So it acts the same way as if it's not seeing blood, and it retains fluid. It retains fluid by it just increases your aldosterone, your angiotensin, and it just retains fluid in the body as if it's not seeing any perfusion. And we have the direct, as I said, direct vasoconstriction from the sympathetic trunk just to increase the flow. Unfortunately, all these mechanisms sound great to begin with. They sound compensatory, but if left uninhibited, if left, they actually cause detrimental effects. So the more vasoconstriction you get, the lower the cardiac output is. You cut off the blood supply totally. The more stimulation of heart rate you get, the more exhaustion the body gets. The more retention of fluid that you get, the more loading of the heart. So all these mechanisms, although look in the beginning promising, they eventually worsen the heart failure. And our role as clinicians and physicians is simply to block these mechanisms. So we block the angiotensin system, we block the aldosterone, we give vasodilators, we block the sympathetic hyperactivity by beta blockers. This is simply what we do. And I would just like to stress a little bit on the role of heart rate because of the increased adrenergic system that we get classically in atherosclerosis and ischemia by increasing the oxygen consumption and worsening the coronary perfusion, but also in heart failure, you increase the oxygen demand and you decrease the ventricular efficiency and you decrease the ventricular relaxation and you shorten the diastolic time, so you worsen your heart failure. And it has been shown significantly in many studies that the higher your heart rate, the worse your outcome is and the worse your survival in patients with heart failure. And it has in many studies, the cutoff has been more or less the 70 as a cutoff for heart failure with reduced ejection fraction. Higher than that, the higher you go, the worse your outcome is. So even in the SHIFT trial, it was shown that for every 1 beat per minute increase in heart rate, there's a 3% increase in cardiovascular death and heart failure hospitalization, and a 16% increase for every 5 beat per minute increase in heart rate. Although we think that this 1 beat per minute or 5 beats per minute is not a big deal, but it actually is in patients with heart failure, and it has to be measured accurately, resting heart rate to manage correctly. Several studies even followed that. The Paradigm HF, which studied the sacubital valsartan, also showed a significant increase and worsening cardiovascular events and fatal outcomes, and in hospitalization, with an increase in heart rate above 76. So heart rate is a target by itself to be reduced by several mechanisms that we have. The classic is the beta adrenal receptor antagonisms, and it has several other functions besides reducing your heart rate, also remodeling, because you block the sympathetic detrimental activity. But other mechanisms are blocking the IF channels, the funny channels in the sinus node, by ivabradine, for example, and that will also reduce your heart rate. So beta blockers are known to improve prognosis proportionate to heart rate reduction and significant decrease through different mechanisms. The main is blocking the sympathetic system, nervous system. A reduction in heart rate to reach values lower than 70 is the target to improve survival in patients with HFrEF treated with beta blockers. And as I said, for every increase of 5 beats per minute, there was an 8 increase in cardiovascular death and 16% increase in admission to hospitals. Now, most of us have graduated before we were taught about natriuretic peptides in school. But recently, we have noticed that these natriuretic peptides are very important endogenous peptides in heart failure. They are endogenous vasoactive peptides, and they reduce vascular tone, they reduce neurohormonal activation, they cause natriuresis by its name, and when you cause natriuresis, you cause diuresis as well. Unfortunately, in the body, we have an enzyme called neprilysin, which breaks our natriuretic peptides, so they become inactive. And from there came the concept of what if we inhibit this enzyme by a neprilysin inhibition, we get more natriuretic peptides, and we get better heart failure outcomes and results. And that was true. The combination of a neprilysin inhibitor, sacubitril, with the ARB, the angiotensin receptor blocker, together have been proven, sacubitril, valsartan, the paradigm trial, to improve significantly cardiovascular outcome and heart failure hospitalization compared to the standard of therapy, ACE inhibitors, which was enalapril. So that gives us the basic concepts of managing our heart failure from relieving the vasoconstriction by sympathetic nervous system blockade, by the renin-angiotensin system and aldosterone system, and also causing vasodilation and natriuresis by the natriuretic peptide system. And from that came the guidelines following. This is the American College of Cardiology, American Heart Association guidelines, and based on these mechanisms and, what is more important, the evidence that all patients with reduced ejection fraction, and again, reduced ejection fraction less than 40%, and New York Heart Association class 1 to 4, so whether they were symptomatic or not symptomatic, one totally asymptomatic, they should be on an ACE or an ARB and a beta blocker. Then, the second step, if these patients are symptomatic, then we should consider one of these options. Adding aldosterone antagonist, switching to an ARNI, or adding hydralazine nitrate, especially in the Black population, an ICD, or a CRT, cardiac resynchronization therapy. And if patients are above 70 heart rate, above 70 and symptomatic, then ivabradine, the IF channel blocker, should be considered in these patients. Now, this is the American College of Cardiology opens it more into the choice of the physician to choose which step he would like to go. The Europeans were more strict, and they put it in a very stepwise approach. You have to start with an ACE inhibitor, and if intolerant or cough, you might use an ARB. Now, if they are symptomatic, you would add an MRA. Still symptomatic, then you switch to an ARNI, and heart rate above 70, use ivabradine. Our guidelines in the Saudi Heart Association was more or less like that, but we thought that ACE or ARBs in the beginning has probably the same, especially if the patient is already on an ARB. Many of our patients, hypertensive, for example, or renal dysfunction on an ARB anyway, you can still continue. And if the patient is asymptomatic, then you can go either with an ARNI or an MRA based on these guidelines. Now, moving to the newest, because those guidelines were in 2016, 2017, there is a lot that happened after that. I know I'm in an endocrine symposium, and I don't have to go through the details of what SGLT2s do, but specifically they block the reabsorption of glucose and sodium, increasing the glucose in the tubules and the sodium, causing more diuresis and natriuresis, and eventually helping both diabetes and heart failure. But these SGLT2 receptors have been found in the heart as well, and we're still to learn how they work in that too. What is of note and importance here is the role in heart failure. The DAPA-HF trial came very positive in patients with heart failure, reduced ejection fraction less than 40%, whether they were or not diabetic. It showed a significant reduction in primary composite outcome, cardiovascular death, heart failure, hospitalization, and urgent heart failure.
Dr. Walid, 1 minute more, huh? Dr. Walid, 1 minute.
Okay. There was a reduction in the components of the primary outcome, worsening heart failure and cardiovascular death. And just to note that whether the patients were or were not diabetic did not matter in the outcomes. Cardiovascular death or heart failure hospitalization was significantly reduced. Now, all-cause death was also significantly reduced by this drug. So now this drug is obviously a heart failure drug, not just a diabetes drug, and it doesn't matter if you are or not diabetic. And the last, the newest kid on the block is the vericiguat, which is basically a soluble guanylate cyclase stimulator that directly stimulates the SGC, increasing the cyclic GMP. This category has been used for a while in pulmonary hypertension, but now has been shown to be very effective in heart failure, and the Victoria trial showed a significant reduction in primary outcome, mostly driven by reduction in hospitalization for heart failure. I hope I was able to give an outcome of the mechanisms of the work of medications in heart failure with reduced ejection fraction, and thank you for having me again. Thank you.
Thank you, Dr. Walid, for the nice review for the management of heart failure. I know you have a meeting, so we'll get the questions for you now. I know you want to leave, so I have a few questions. The first one, do we need to do echo for every diabetic patient as a screening?
This is a very nice question. There is no evidence in the studies or guidelines that an echo for every patient, a diabetic patient, will help. But an ECG at least, and I stress on that, an ECG should be done for every diabetic patient. And some might disagree with me, but I believe a BNP or a pro-BNP should be done at least once a year for every diabetic patient, because it has been shown in many studies that it predicts heart failure up to 6 months prior to the event. So if patients has no specific symptoms of cardiac symptoms like chest pain, shortness of breath, and no ECG changes or BNP elevation, there is no indication for it.
Okay. The second questions. We have diabetic patients with heart failure on diuretics. And when we start the SGLT2 inhibitor, do we have to stop the diuretics? As you know, the SGLT2 has a diuresis also.
So this is a very critical point, because I've heard some people recommend that once you start the SGLT2 stop your diuretics, and this is very risky. I've seen patients decompensate their heart failure and come with worsening heart failure just because you stopped it. These are special patients. These are critical patients that have been dependent on their diuretics. Yes, SGLT2 might cause diuresis, but by the way, they are glucose-dependent diuresis. So if the blood sugar is not that high, they will not have that significant diuresis anyway. So what I recommend, and the heart failure community recommends, that these patients just require closer follow-ups and monitoring to see how their response is. If you feel that they are becoming dry, they don't have any more shortness of breath, JBP is not elevated, no low edema, you might back off on the diuretics accordingly, and that's what we do with the heart failure patients, but not an automatic reduction or stoppage of diuretics once you start SGLT2, please.
What about reducing the dose of diuretics in this case?
Now, if you are sure that this patient has a big load of glucose and that it will cause diuresis, you might reduce the dose a little bit, but again, with a very close follow-up to make sure that the patient is not worsening symptoms.
Okay. So I have these questions, but should we measure BMP for every suspected cases of heart failure?
Yes, and a big yes, please. Pro-BMP is very critical in diagnosing, and I do recommend it for all our hospitals, and I do shout out to the Ministry of Health to get it in other hospitals, because it has the strongest negative predictive value. If it rules it out fully, and if it is significantly high, you know it's heart failure. There are the gray zones where it's mildly elevated with some renal function things, but if it's very high or totally negative, then you're very comfortable diagnosing and managing these patients. Yes.
The last question, what if the difference in the management of the heart failure would reduce ejection fraction and heart failure would preserve ejection fraction? Please.
What is the major difference?
The difference, I think, in the management.
Yeah, it's a huge difference. Unfortunately, ACE inhibitors don't have a role. ARBs only, candesartan has a reduction in hospitalization. Now, SGLT2 inhibitors, dapagliflozin, is ongoing a study right now called DELIVER in preserved ejection fraction, which I hope will be positive. Aldosterone antagonists have shown only reduction in hospitalization. So unfortunately, most of the studies have failed to show any significant medications. It's only diuresis and control of the risk factors or the comorbidities, diabetes, hypertension, and obesity and hypothyroidism, like that.
So at the end, thank you, Dr. Walid, for...
Thank you very much, and I wish you all the best. Thank you.
Thank you. Thank you. So the last speaker for the first session, it will be my colleague and my friend, Dr. Saud Al-Sifri. He's a professor of medicine at Taif University. He's a director of diabetes and endocrine specialist center, Breast Mansour Hospital. Also, he is the chairman of the endocrinology and diabetes department at Al-Hada and at Taif Armed Forces Hospital. And Dr. Saud, he is going to talk about the unlock barriers to achieve ultimate control. Welcome, Dr. Saud.
Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Khalid, and thank you for my great colleagues and teachers. And for sometimes I thought that I'm coming in by mistake in a cardiology meeting, because since Dr. Ayman and Dr. Walid were talking, I was so much impressed. But luckily, I've got my colleague who's in the same age, Dr. Saeed Khidr, the same experience. So at least maybe we could compete with the cardiologist. So again, I'm very happy that we at least we have got, I would say, a point where we can meet as endocrinologists and cardiologists, which is the heart and diabetes. And I think from here, I would take you and I would shift the gear again back to what we were talking about is the fixed ratio combination and the way of overcoming those barriers in a better way of controlling diabetes. And we knew how good we do, how jobless our cardiologist will be. So I think if we are doing very good and great job in controlling patients, preventing complications, heart failure, major adverse cardiovascular events, then I think maybe our colleague cardiologists might not find anything to do except taking their endocrine fellowship again. So without this, always we would say it's very good to manage diabetes, but sometimes it becomes very difficult when you go into advanced stages where you would need to intensify treatment. And when it comes to intensifications, most of the time you would need the agreement and the consent of your patient, because he's the one to take those medications, and he should take care of this management. Now, in this, always we wanted to make it as easy for patient as possible. So that's why you would find people are talking about different new molecules, a better convenient way, making it very simple, because management of diabetes is very complicated. And the more you would make it simple, the better your patient is going to adhere, and this is going to be reflected as outcome of your patient's response. Here we're going to talk about different technology. Here we are trying to fix two different things. One of them is the basal insulin, and here it is insulin glargine U100 Lantus, and the other one is lixisenatide. And what is so special about lixisenatide, I would tell you now. And these two, we are going to combine it together in a fixed ratio, and that is going to have the product called iGlarg Lixi, which is Soliqua. And we would go over this and what would be the advantage of having both of them. All of you are aware that U100 glargine has got the basal components of insulin, which covers 24 hours, and that by that it is going to reduce the hepatic glucose output as well as the peripheral. It will increase the peripheral glucose uptake by the muscles and adipose tissue, which would result in reducing their fasting. But it does not have any effect on the postprandial or the mealtime insulin. That's why we are going to combine it with another molecules, which is the glucagon-like peptide 1 receptor agonist. And in this situations, it is lixisenatide. And this lixisenatide has got a short duration of action. It has got like a rapid-acting GLP-1, where it simulates the natural GLP-1, which is secreted from our intestine, where it would have a peak, and that peak, it would have more of glucose-dependent insulin secretions and suppression of the glucagon, along with a mechanical gastric emptying decrease. All of this will lead to reduction in the postprandial. So by this, we are going to have the complementary action on both the fasting components as well as the postprandial or the mealtime component of glucose control. Just to show you what is the difference between what we call it prandial GLP-1, like lixisenatide, where if you would see here in the blue one, once it has been given to almost 150 adults with type 2 diabetes who were not controlled, and then they were measuring their serum glucose after taking the meal, you would see that the one in the dark blue, this was the effect of having liraglutide, in which we call it a long-acting GLP-1, where it did not have much effect on the postprandial. While here, if you would see this with the orange, it is the lixisenatide, where it has got a reduction in the mean glucose after 2 hours of injecting it in diabetic patients, where it has got a reduction in the postprandial compared to those with liraglutide, where there was no effect. Now, let's see what would happen with the excursion of this lixisenatide. You would see that the combination of Soliqua, which is the basal insulin component, insulin glargine and lixisenatide, it has got almost a reduction of 2 hours postprandial by 42 milligram per deciliter, compared to a minimal or almost no effect with glargine and maximum effect of 58 milligram reduction by this. So it has got the component of lixisenatide reduction in this. Now, again, if you would compare it here on the 2 hours, you would see that with iglar-lexi, which is the Soliqua, there was again a reduction in the 2 hours postprandial by almost 126 compared to the end of the duration period, which is 30 weeks or 6 months. There was significant reduction by almost 70 milligram per deciliter. So from here, you would say that definitely there was a reduction with this, and this was the effect of having the lixisenatide, the prandial GLP-1 with us. This is the 7-point self-monitoring. And again, here you would see, if you would compare the baseline to at the end of the trial, which was 26 weeks, you would see that with Soliqua, there was significant reduction of the 2 hours postprandial, whether it is after breakfast or lunch or dinner, by a very significant, compared to almost no change with insulin glargine. And this is well known, but this is just to prove that insulin glargine or basal insulin does not have an effect on the postprandial compared to lixisenatide, where it is a prandial insulin, where it is a prandial GLP-1. Now again, there was a significant reduction, if you would see here in the postprandial with lixisenatide, and this is again from lixisenatide glargine trial, you would see that there was significant reduction in terms of their postprandial at all 2 hours postprandial, and again here at the fasting plasma glucose. So from here, you would see in all of them that there was a reduction by Soliqua, which was very significant compared to giving only GLP-1 receptor agonist. Now, this is an interesting study where they wanted to see whether giving lixisenatide with glargine basal, which is prandial GLP-1 lixisenatide with basal insulin glargine U100, versus giving what we call it, the basal plus or basal bolus, which is the basal plus 1 or 3 mealtime insulin. Does it have non-inferiority with this? So they have chosen newly diagnosed type 2 diabetes, whom they are poorly controlled on the basal insulin, plus minus oral hypoglycemic agents. So what they did, they randomized them, more than 1,000 patients. They had been randomized either to receive basal bolus, which is 1 basal and 3 boluses of insulin, glulicine, with the time with the meal, or they have been given 1 mealtime insulin along with the basal insulin, and then the third arm was lixisenatide once a day along with insulin glargine. And they wanted to see the change in the hemoglobin A1C plus other secondary endpoints. So just to tell you from here, when they have started, it was 8.5, their baseline hemoglobin A1C. And then if you would see those who had received the basal bolus or basal plus type of insulin compared to Soliqua, they have got non-inferiority. So from here, we would prove that using Soliqua as once daily, it has got non-inferiority to basal plus or basal bolus insulin. This was very interesting. And again, here they wanted to look into the other secondary endpoints, in where here they looked at the body weight, and you could appreciate that by using here Soliqua, they have lost like something like 1 kg, while the other group who had received intensified insulin, they have got weight gain, in which the difference between them was significant. So from here, we would say that either giving once Soliqua or 3 or 4 injections of basal plus or basal bolus insulin were having the same efficacy in terms of A1C control, but the weight, there was more weight gain in the insulin arm with this. Now, the second advantage was the symptomatic hypoglycemia. From here, you would see those who had received Soliqua, they have got fewer and less symptomatic hypoglycemia, plus they did not have any severe symptomatic hypoglycemia in those patients compared to those who had received either glulicine once or 3 times along with the basal insulin. So this tells you that it has got even a better safety when it comes to terms of weight gain or when it comes to hypoglycemia. So with those, we could conclude from this that definitely using Soliqua once a day compared to basal bolus or basal plus, both they were equally effective in reducing the hemoglobin A1C. But here it has got fewer injection, it has got less glycemic or glucose monitoring because you would need to monitor it once a day. It has got a better adherence because it's one injection, more of weight benefit, and again, less hypoglycemia with definitely decreased or reduced insulin doses. While here, definitely once you start GLP-1, it has got more GI side effect in terms of nausea and vomiting, but again, it was less when you compare it to the free GLP-1 giving it. So if you are going to give GLP-1 alone, definitely it would have more of GI side effect compared to that. The other disadvantage is the cost and affordability, and this depends on the patient insurance and availability in a hospital. This is another interesting study where I'm not going to bother you with many of those trials of Soliqua. So here we are going to talk about in those patients who had not been yet controlled. So they are taking maximum oral and then plus basal insulin, and yet they are not controlled. So in that situations, what we are going to have, we are going to have an option of either randomizing them to either they would receive what we call it basal insulin and then up titration of that basal insulin dose, or we are going to give them Soliqua in that fixed dose. So here they randomized almost 800 patients with type 2 whom they are not yet controlled, and they have got fasting plasma which is yet less than 180. And in this, they are going to randomize them either up titration of their basal insulin lantus, compared that they are going to give them Soliqua one dose, and they are going to see it in 6 months. So the main thing we are going, the primary endpoint, we are going to look for the hemoglobin A1C, plus we are going to see how many of them as secondary endpoints they have got benefits on. The other thing is the safety issues with this. So this is just to tell you that the main median average age was 60. So here we are talking about a population which is obese, elderly, 60 years, and their average or baseline hemoglobin A1C was 8.1 with long duration of diabetes like 12 years, and their insulin duration was 3 years. So here we would say that we are treating here patients who have got longer duration of diabetes, and despite this longer term of basal insulin use, and despite this their A1C is not yet controlled. Let's see what happened. Those who had been up titrated their doses of basal insulin, they have reached almost 7.5 from 8.5, if you would remember. So almost 1% reduction. Now let's look at those who had been given Soliqua. Again, in a 6 month, you would see that they have reached 6.9% of hemoglobin A1C, which is a very significant superiority for using this in terms of this. Now let's look at how many of them they have achieved their A1C less than 7%, definitely double of this. So 25, and the other is almost 55. So double of those they have achieved there. Now how about A1C less than 6.5? Again, here 14% for up titration of basal insulin, compared to almost double of that, which is 30% increase or a better achievement of this. So more reduction in this. Now let's look at the fasting and the postprandial. If you would remember, we would say that both of them, they have got, in terms of their fasting, they have got a better reduction. But now let's look at the postprandial. And if you would see here, at the end of the trial, those who had received Soliqua, they have got almost 3.9 millimole, which is equal almost to 80 milligram of reduction of A1C of postprandial. So again, superior and more potent postprandial reduction, as well as equivalent reduction of the fasting in terms of glargine. So now let's look at the body weight. Those who had used one dose of Soliqua, they have got a reduction of almost 1 kg, while the other they gained 1 kg, and the difference between them was significant. So here you're getting the benefits of basal insulin, glargine, without the adverse events of weight gain by using it. Now let's look at the adverse events, and you remember the GI side effect is the main adverse events of having the GLP-1. But here the good thing that once you start this Siliqua, you've got almost half of those GI side effects, which you would expect it once you're going to use individual GLP-1. i.e., if I'm going to start GLP-1, I would expect almost 20 to 10% GI side effect. While if I'm going to use it in Siliqua, which is small up titrated of the GLP-1 dose, with that I would expect half or less of these GI side effect with Siliqua. And the good thing that it's always mild to moderate, and it is self-limited. And usually what we have seen that within 8 weeks, 4 to 8 weeks, most of these GI side effects are finishing. Now let's see, does it make a difference if I'm going to start Siliqua, whether my patient has got an A1C less than 8 or more than 9? Does it work in all situations? Here, very quickly, just to show you that if we stratify them based on basal baseline hemoglobin A1C, it works at all level of baseline A1C. If your patient has got an A1C less than 8, definitely you would expect a reduction of more than 1.1% compared to insulin glargine, which is 0.5. And here, if it is between 8 and 9, almost 1.1. And here, with A1C baseline of more than 9%, you would expect almost 2.5% reduction by using Siliqua. And this was superior to basal insulin at all levels. So this was reassuring that in terms of this, it works at all levels, and it doesn't, the higher baseline A1C, the more Siliqua you would expect them to have. Now, again, here, just to show you from this, how many of them they have achieved their hemoglobin A1C less than 7%. Always remember here, if all patients, regardless of their baseline hemoglobin A1C, you would see that almost double of those. So if you would achieve 30% of your patient would achieve it with the basal insulin, always remember that double of this, 60%, they would achieve it with Siliqua. So to see what we have gained by using the Siliqua, which is the fixed ratio combination of lixisenatide, brandial GLP-1, and the basal insulin glargine U100, it demonstrated that it has got the reduction, significant reduction of hemoglobin A1C with more than any individual components of it. It allowed more patient percentage to achieve hemoglobin A1C, almost we would say double of those who would achieve it on the basal insulin. It improved the glycemic control without increasing the body weight or symptomatic hypoglycemia if you would compare it to insulin basal glargine. And the other thing, it has got favorable, less GI tolerability profile when you compare it with GLP-1 receptor agonist alone. I'll just take you through some of the other studies very quick. When you wanted to compare those whom you want to use either Siliqua or basal bolus in those patients. And this is an interesting study where it included 200 patients in each arm. So they were randomized. Either they're going to receive Siliqua once daily, or they are going to receive insulin glargine and insulin glulicine. So basal bolus. And in this 400 patients, if you would see their baseline is almost 60 years age, and we are talking about hemoglobin A1C, an average of almost 7.9, with almost duration of diabetes by almost 13 years. Now let's see. Again, here you would see that there was a greater reduction with Siliqua compared to those basal bolus. So here in this study, we are seeing even a further reduction or a further superiority by using it compared to basal bolus. Now, again, if you look at those who achieved A1C less than 7, again, more than half of your patients would achieve it compared to only 1/3 with basal bolus. And again, hypoglycemia or weight gain, it was even less, very significantly less with using Siliqua compared to the other. Now, the composite endpoints of those three favorable effects, better glycemic control with no hypoglycemia, no weight gain, definitely here you would have almost half of your patients are having this by using Soliqua compared to 25% where they are going to use the basal bolus. Definitely we knew basal bolus is the gold standard, but now here when it was compared, it was found that it was even better. Now here again, when you look at Soliqua compared to those who receive basal bolus, again in terms of weight, definitely here they are losing almost like half kg, while in the other they are gaining almost like 1 kg. When you compare the difference between both arms, there was a better favorable effect on that. Now hypoglycemia, definitely it was significantly less by 30 to 60% when you compare either mild, either moderate or severe hypoglycemia by using Soliqua compared to the basal bolus regimen. Now to conclude with those from those studies, definitely by using IGLAR-Lexi, which is Soliqua, definitely it has got a better or greater reduction in A1C with less weight gain and less hypoglycemia when you compare it to basal bolus insulin regimen in patients with type 2
Dr. Saud, 1 minute. Huh? Dr. Saud, 1 minute.
Okay, I'm concluding with the final two slides. So here it was associated with greater proportion and percentage of patients who achieved both composite endpoints, no hypoglycemia, A1C less than 7, and no weight gain. And again, it has been only 1 injection compared to 3 or 4 injections a day by using the basal bolus. And always in this, we would say in those who had been uncontrolled in basal insulin, treatment intensifications with IGLAR-Lexi, which is Soliqua, is usually more efficacious, well tolerated, and very convenient than switching them into multiple daily injection therapy. This is how it looks. It comes in two kinds of pen, one pen for initiation and the other one for intensifications. Always don't worry about the components of the GLP-1 or lixisenatide with the glargine, because usually you titrate according to the insulin need. So you need only to measure the fasting plasma glucose, and according to that, if still uncontrolled, you would need to increase it based on the requirements of the basal insulin. Along with it, you would find small increments in the GLP-1 lixisenatide. So always we titrate according to the insulin glargine rather than the other thing. This is how it comes. So it comes 3-to-1 fixed ratio of basal insulin to the lixisenatide. So with this, you could give your patient the flexibility of reaching up to 60 units of glargine and 20 units or 20 milligram of lixisenatide a day. So with this, you could offer your patients, whether a male or female, a complementary glucose control, which address both components, the fasting as well as the postprandial. It has got a favorable hypoglycemia and weight benefits. And again, it's very simple, well tolerated, and even it is simple for physicians not to think much about this. Just think of it as if you are titrating the glargine insulin without the GLP-1 component. Thank you very much for your listening. Thank you.
Thank you, Dr. Saud, for a nice presentation. We know now with the new medication of GLP-1 and SGL2, they made a difference for the management of our patient type 2 diabetes. Now we'll start questions and we'll have a discussion now for 10 minutes. And we'll start with Dr. Saeed. Dr. Saeed, we have 2 questions for you. The first one, when should we stop Victoza? And what are the indicators of failure of response?
Okay, first question, when do we stop Victoza? I mean, first of all, I mean, we have to know the Victoza indication, liraglutide. It is for type 2 diabetes who are overweight or not overweight. It's anti-hyperglycemia. It's not anti-obesity. I know that they are using Victoza off-label for obesity, although they should use Saxenda. But it's contraindicated if there is history of medullary thyroid carcinoma and basically even any cancer. When I ask the patient, do you have thyroid cancer or your family And recently, probably I asked about the breast cancer. Anybody has history or strong family history of breast cancer, I try to avoid using all GLP-1 receptor agonists, as there is some observation recently about a few cases of breast cancer. The other thing is if the patient develop the GI side effects, some of them they develop severe side effects. The other thing, if they develop severe abdominal pain and we are not sure if this is pancreatitis or not, it is a must to stop. I mean, I don't check the pancreatic enzyme all the time routinely, but you have to ask about the history if there is pancreatitis or not. But severe abdominal pain, please stop, okay? If there is typical abdominal pain, radiate to the back, etc. Those patients, for example, alcoholic, they have history of alcoholic hepatitis. The other thing, sometimes we have to be very careful in obese women with gallbladder stone, or warn them that they are at risk probably having more gallbladder problems when they are on liraglutide. Right upper abdominal pain, probably you have to stop.
First, I have a comment or I need an answer. If I have a patient, female patient or male patient with a thyroid nodule, and we would like to start the GLP-1, do we have to do investigation to rule out the thyroid cancer for the nodule, or is it difficult?
I mean, it depends, Dr. Khalid, and probably Dr. Saud and you are endocrinologists. It depends what sort of, is it solitary nodule? Is it just a one? Is there calcification, hypervascularity? Is there suspicious of really cancer? Or is it part of multinodular goiter? And 1 centimeter or 0.5 centimeter, I don't care probably much. Although the recommendation, if there is a nodule, solitary nodule, depending on the age, it's better to do an FNA. We know medullary thyroid carcinoma is very, very, very rare. But again, is it really, are we brave enough to give it if there is papillary or follicular? Of course not. So I will do an FNA, ultrasound guided FNA, depending on this solitary nodule or high suspicious of nodule.
Okay, thank you. And the second question, how can we adjust the dose for fixed ratio insulins? How can we adjust the dose for the fixed ratio?
I mean, the fixed ratio combination GLP-1 and, I mean, as I said, for example, for the Soliqua again, and Dr. Saud showed in his lecture, that by 2 units, as we are titrating the dose for the basal insulin, depending on the fasting blood sugar. For example, Zoltufai, you start 10 units or 16 units for those patients on insulin. You can titrate every 3 days by 2 units, depending on the target that you put. So each individual is different. For example, I need the target for fasting blood sugar to be 100 or for somebody 150. So I titrate by 2 units, depending on the fasting blood sugar every 3 days, not every day. Sometimes, I mean, the Switzerland and some parts of the country, they titrate by 4 units every week. But my experience and a lot of recommendation, every 3 days by 2 units only.
Okay, thank you, Dr. Said. Thank you for. Now we'll go for Dr. Ayman. Dr. Ayman, you hear me?
Yes.
Okay. There's one question. In the low-risk diabetes, type 2 diabetes, how to prevent the platelet aggregation in the microvascular complicated patient?
Very good question, actually. The concise about the ask this question here. I want to ask me what is the role of antiplatelet therapy in patient with low risk diabetic, I think. So I make it very clearly and very simple. Patient with moderate risk, I can say, or patient with very high risk or patient with high risk. To make it simple, patient with very high risk, I can give low dose of aspirin therapy with class 2B indication. Class 2B indication mean if we are 5, 3 of us say, please don't make it. And 2 only say yes. So primary prevention of antiplatelet therapy in patient with very high risk, it is class 2B indication, with class 2A indication with protein pump inhibitor. But the usual one, which is diabetic only with moderate risk, you can say big no for antiplatelet therapy as a primary prevention.
Good. This is the second question. I think it's very important for us also. Can we use the dapagliflozin for management of heart failure in patient without diabetes?
This very nice question. I'm waiting for Saudi heart, FDA Saudi to say, please, we allow you. But for me, as a practitioner, as a pure cardiologist, I'm still saying no, this for you as an endocrinologist. So for patient with heart failure alone, without diabetes, I am waiting the permission from FDA Saudi to say yes. So if I give it now, it is off-label.
Is approved by FDA United States American.
Definitely.
Even without diabetes. Okay. Okay, Dr. Ayman. Thank you, Dr. Ayman. Now we'll go for the Dr. Saud. Dr. Saud, we have two questions for you. The first one, when to start the combination and who is the best candidate for it? Okay. When to start the combination and who is the best candidate for it?
Okay.
For the combination therapy.
Oh, yeah. Thank you very much. Again, this is an interesting question. When do we use the
combination?
The combination, those fixed ratio combinations, and who is the best candidate? Now, the best candidate could be anyone, but now when to start it? At any time where your patient has failed his oral anti-diabetic agent, I think he's a good candidate for a fixed ratio combination. And here, if we talk particularly about high glycemia, I think it's a good option in those, especially if they have got high baseline A1C. So if my patient is taking 2 or 3 orals, and despite this, his hemoglobin A1C is around 9, plus he has got the problem of both. The fasting is very high as well as the postprandial. In that situation, I think fixed ratio combination is best intensification or a best way of starting intensifications. Now, the second options in those who are using already basal insulin and they are not yet controlled, then definitely I would prefer to start them with a fixed ratio combination to intensify rather than giving him 2 injections alone. Now, the third one is really somebody who's taking the GLP-1 receptor agonist with the oral, and despite this, he's not yet controlled. In that situation, I think putting him on fixed ratio combination would be a good solution. So I think this is an option. This is an technology, very simple to use it, but only choose the right patients for it.
Okay. What do you think about patient with the A1C lower than 8, but above 7, and he is on just glucophage or metformin? Do you prefer to add the second oral and third oral, or to start the GLP-1 or SGLT2 inhibitor? What the guidelines? We know with guidelines to add the second and oral and the third, and after that. But with the new study, shows the benefit of these 2 groups of medication. What's your opinion? What's your recommendation?
This is an ideal patient who's newly diagnosed only on metformin, and yet his hemoglobin A1C between 7 and 8, so he's moderately uncontrolled. In that situation, I would use either one. Maybe I would go for SGLT2 inhibitors if there is no contraindication, or I might add for him GLP-1 receptor agonist if he's having a profile of weight issue or weight concern. I might not go for the fixed ratio combination at this early stage. I might delay it for some times, but I think if he's willing to take an injection, GLP-1 would be a good option. If not, then I would go with the SGLT2 inhibitors if no contraindication.
Especially if they have a cardiovascular background of the patient here.
Excellent. Yeah, that would be an ideal, and again, according to the guidelines, it should be in one of those.
The second question for you, Dr. Saud. What is the dose combination for glargine plus GLP-1, and what is how dose alteration? I think. What is the dose combination of glargine plus GLP-1?
Okay. Here we've got 2 kinds of pen of Soliqua. And the good thing really for patients who are already, you're going to initiate him on Siliqua. So please use it as if you are using the glargine. So it has got a glargine with it.
Yeah.
Use it as 10 units and then titrate it every 3 days by 2 units if he needs increase. So forget about the components of the GLP-1 lixisenatide with it. Now somebody who had been using already basal insulin, glargine, you want to give him Siliqua. The good advantage of Siliqua that you can give him the same dose. If he was using, for example, 20 units of the glargine, basal insulin, then you give him Siliqua 20 units. So with that, he's going to receive the same. So you shift 1 unit to 1 unit. Unless if he's more than 30 units, then you bring him down to 30 units.
So it is easy, not that difficult to start.
No, not at all. Yeah.
So at the end of this session, I would like to thank all the speakers, and we'll take a break for 20 minutes and we will come back for the second session at 9 o'clock. Thank you all.
Thank you very much.
Thank you.
Thank you.
Bye.